Okay, so I'd like to first hand over to Daniela Carl, our CEO of GIN Guidelines International Network. Thank you, Daniela.
Thank you, Rosa. Hello, good afternoon, good evening. A very warm welcome to all of you, and thank you for joining us today for this webinar organized by the Guidelines International Network's Arab Regional Community. As Rosa said, my name is Daniela Carl. I'm the Chief Executive Officer of the Guidelines International Network, and I'm very pleased to be here with you today. So I would like to use the next couple of minutes to give you an overview of what GIN is and what we do. So the Guidelines International Network, or in short, GIN, is a global network of organizations and individuals who are committed to evidence-based guidance and better health outcomes. At its heart, GIN and its community are dedicated to improve healthcare by supporting the development of high-quality clinical practice guidelines and helping put them into everyday use. We do this by bringing people together from different geographies and cultural settings, professions, and health systems to learn from one another and work collaboratively. Today, GIN connects members in across 56 countries, creating a space to share knowledge, experience, and diverse perspective from around the world. GIN is truly global. As I said, we have members in 56 countries, and one of our strengths is to bring people together in different ways. We support collaboration through 7 regional communities, for example. GIN Arab is one of those. Others are in North America, Africa, Asia, Australasia, and New Zealand. And these communities create space for regional dialogue, shared challenges, to share challenges and local leadership. Along those regional communities, we also have topic-specific working groups. We currently have 19. You can see the different ones that are active at the moment on the screen, and each focuses on a particular area of practice or methodology. These groups are collaborative and open to engagement from across the community. And it is the combination of the global connection and the focus collaboration that allows our working groups to have real impact. Before I close, I'd like to highlight this year's annual conference. So this is our main event in a year. This year's GIN 2026 will bring together international experts, senior policymakers, clinicians, researchers, patient advocates, and healthcare leaders in Kuala Lumpur in Malaysia this September. And you get more information on the conference via the QR code on the screen. Please do reach out if you want more information on any of our work. But without further ado, I shall now hand over to Lubna and wish you all a good webinar. Thank you. Hang on.
Thank you very much, Daniela, for the nice introduction. And I would like to, I'll probably need to, yes, okay, I hope I can, I think we need to, you need to unshare your screen so I can share mine. And I would like to welcome everybody. And I'm glad to see that you're so active in the chat. Please let us know who you are and where are you coming from, what do you do, and what are your activities and institutions, deliverables. It is the platform that we hope that we can share forces, join forces through, and make our region a leading region for guideline development and evidence-based policy making in the area of guidelines and in other areas as well. I don't know what's going on. Okay. Can you see my slides? Are they clear?
Yes, we
Yes.
can. Perfect.
So in the next 10 minutes or so, I'm going to talk about the basics of clinical practice guidelines and set the pace for the presentation that would follow. What are clinical practice guidelines? Why do we need them? And when do they work? And how can we use them? How can we properly use them? And just in case you don't know me, I'm Lubna. I've played so many roles in my professional career, and I think these roles would lend themselves one way or the other to clinical practice guidelines. So in a way, I was wearing the hat of different stakeholders or interest holders in the field of clinical practice guideline development and implementation. This is who we are. This is the 22 Arab countries, Arab states, according to the Arab League. And in total, we are a little more than 500 million people. And more than half of the population is under the age of our youth. And we have differences. So we have small countries and we have large countries, and we have plenty of differences, but we have plenty of similarities as well. And these similarities and the scale and the scale that we and the youth are the things that we need to consider seriously when we are thinking in terms of guideline development. Sorry. So this is the basic or the official, I would say, definition of clinical practice guidelines that was launched by the Institute of Medicine in 2011, now the National Academy of Medicine. And clinical practice guidelines are statements that include recommendations intended to optimize patient care that are informed by a systematic review of evidence and and an assessment of the benefits and harms of alternate care options. So they are statements that would help in guiding care based on systematic reviews, based on the best available evidence, and each recommendation would have an assessment of the benefits, potential benefits, and potential harms of implementing them. The evidence to practice gap is there. We all know that is there. Whether it lasts 17 years for the evidence to be put in practice, or whether it is more or less than this, probably it is less than this now. I recall that when James Lind identified vitamin C as the way to manage scurvy, it took 50 years to put in practice. But this is usually the figure that is quoted in 2011, and it is still quoted till now. It doesn't matter exactly, even if we're talking about 10 years, it is the amount of evidence that is there is too huge for a single clinician to capture all this and appraise the entire body of evidence. And guidelines are a way to summarize and digest that evidence into a usable format. So guidelines exist to close the gap, the evidence to practice gap. What guidelines do? Guidelines would serve the needs of every stakeholder or interest holder. But here I'm referring to the main, I wouldn't say the main, but the three that are usually dealing with guidelines more than other stakeholders. So for patients, guidelines would provide more consistent evidence-based care and safer decisions. For clinicians, guidelines would help summarize unmanageable evidence-based into recommendations that are usable. And for health systems, the implementation of guidelines would result in less unwarranted variation and more of a shared basis for quality improvement, audit, and so on. So it is one tool, and they serve different needs for different interest holders. Now, do guidelines help? I guess if we're having the Guidelines International Network session in the Arab regional community, we believe that guidelines would help, but there are conditions. Yes, they would help, but this yes is qualified. It's qualified in the sense that we need to have sound guidelines that are truly prepared using the highest and the best methodological rigor. We need these guidelines would lead to clinician change in behavior, and then that behavior, the new behavior, is implemented, applied when dealing with patients, and patients would improve as a result of following the new recommendation, and that improvement is reflected in patient outcomes. It's only with these steps or these conditions that guidelines would really help. So implementation is the decisive variable, and it has to be done properly. But a guideline that is just there, nothing is in the drawer anymore, but it is just there somewhere without really being put in practice, probably is not enough, and it's useless. Do we have evidence that the implementation of guidelines improve care? We do, and I'm presenting here two examples, one from the emergency, from the acute care domain, and that is the results of implementing the WHO surgical safety checklist, a 19-item checklist that has been used across 8 hospitals. And I gathered that one of these hospitals was in Amman, in Jordan, and it has led over 1 month to the reduction of surgical death from 1.5% to 0.8%, almost half. And another example from primary care, from chronic and outpatient care, where the implementation of recommendations related to blood pressure, hypertension management led to blood pressure control to rise from 44% to 80%, which has been even above the national average for the US. Now, can we afford ignoring the evidence? Well, it's a question that probably has the answer in it. But what would happen if we ignore the evidence? We would end up in one of these failure modes. Either there will be overuse of interventions that are not evidence-based, as is the case for the overuse of C-section in some of the countries, whereas the WHO is about 10 to 15%, or misuse, as is the case with the use of antibiotics that is not justified, leading to AMR resistance, or there is underuse, as is the case with diabetes, for example, where it is probably the most common NCD in our region, yet many, at least 1/3 is underdiagnosed and undertreated. So evidence may be universal, but the applicability and the implementation is the key word for our region, and that is the local part. We need to pay attention to the population we have, the resources, the availability, the patient values. So adaptation is not simple adoption. We cannot ignore the evidence, and we're not going to blindly apply the evidence. We need to evaluate it and contextualize it and modify it in a way that suits our needs. So what we are calling for is the skilled engagement and the skilled application of this evidence, not simply using it as a cookbook. So while we are talking in most of our work, especially as an educator in at the university and in other context, we are usually talking about individual patients and the direct communication between a physician and a patient. Sometimes in primary healthcare in general, we are talking about a regional in the sense of a catchment population approach, but and possibly at a national scale. But we need to move from that into talking about how can we apply the evidence at a regional level. And the Arab region, the EMR region, is a great example, and that's what we need to do in the future. And that paves the way to introduce the fantastic work that is being done by WHO EMRU under the leadership of my colleague Arash Rashidian. So, sorry. So, I will take the opportunity to introduce Arash Rashidian, Professor Arash Rashidian. It's a pleasure to introduce him. He's the next speaker, and he's someone that I had I thought you only had this laryngitis. I don't, but it seems that I'm catching up as well. So the Professor Arash Rashidian is someone that I had the privilege to know him for so many years. He leads the science, innovation, and data agenda at the WHO Regional Office for the East Mediterranean. Since 2019, he has been at the very heart of our region's work on evidence-informed policy and health information systems and research. He's a professor of health policy, and his career spans over 25 years and more than 20 countries. And he's currently an affiliate professor at the University of Washington, and he's the executive editor of the East Mediterranean Health Journal, which is EMRU's flagship publication. And for this webinar, his fingerprints are on everything we care about. He served as the vice chair of the WHO Guideline Review Committee. And during COVID-19, he led the research and knowledge management pillar of the WHO response across our region. And he has attended our previous meetings. I recall when we were in Prague, he was there in the Jinn Arab meeting. Beyond titles, and he has many titles, Arash has been one of the most generous and influential contributors to building evidence and capacity across the Arab world. And it's a genuine honor to hand him the floor. So welcome, Professor Arash Rashidian. The floor is yours.
Many thanks indeed, Professor Ansari. This was a very generous introduction, and I'm grateful for that, and I hope I deserve such praise. I mean, but in any case, this is working with several esteemed colleagues, including yourself. Many colleagues that are on the call have been involved in different aspects, and I refer to those. I have the pleasure, I'm very grateful to you, to Daniela, to Rosa, and all colleagues for the opportunity to talk. I start with sharing my slides so that we go ahead more formally. So I put it on the slideshow. And the colleagues, I also need to make an apology from the start. I have had some flu and my voice is not working properly. I hope it will survive the talk, but I try to go through that process. So my focus, obviously, I mean, given that we are in the Jinn platform discussion, so I will give the main focus on guidelines, but the main approach, as Lubna mentioned, is about institutionalizing evidence-informed policymaking, and the focus, obviously, in our region. When we talk of Eastern Mediterranean region, so our catchment area is slightly different from the Jinn Arab, catchment area, but most countries are shared, and this is the experience we are going to focus on. One thing to mention, I want to refer to this SDG progress report in our region as a background. This report, it was our second update. We are hoping that the next update will come within a year or two. It showed that the progress is not good. So in terms of health outcomes in the region and with all the conflicts and challenges we see in the region, we are hoping that we will do better. but that challenge remains. Part of it is also about how best we use the available evidence, the resources, etc. And this call is and this webinar is linked to that. Again, within that agenda, we do capacity buildings. I've just put the slides of the last year, 2 rounds of webinars, and those are also available to all, including all colleagues and in the region and beyond to attend. So, I mean, Lubna referred to that. I mean, many of you have seen this slide before, so it's not, the cartoon is not from me. But in a way, the mismatch between evidence and policy is a well-known motto, but the challenge is not always the sort of, I mean, one way or the other, is actually how we also address the program in a systematic way. Having said this, what we did in WHO, and Lubna referred to the regional committee resolution in 2019, and regional committee is the platform that ministers of health of the region decide about WHO agenda. And within that, we proposed an agenda for evidence-informed policymaking, for institutionalizing capacity at national level, and it was approved. And since then, this has been our major agenda in these areas. What is important, I want to show you the sort of the framework here. And we call it the sort of integrated multi-concept approach for institutionalizing evidence-informed policymaking. The reason I'm saying that is that it's not talking about one approach. So guideline program is here, health technology assessment program, knowledge translation processes, data systems, surveys, and other sources of evidence are all together within this approach. This was revolutionary at the time we sort of proposed it, and not just in our region, at the global level. This was probably the first formal document globally that bringing all these agenda together. And in that sense, the reason I'm saying that sort of it was revolutionary, because in most of the programs, I mean, what happens is that there are, even in countries that they have capacity, and even the sort of organizations that they provide support for evidence-informed decision-making, guideline programs are separate, HTA is separate, other processes, they are not talking to each other, they are not linking well with each other, and they are not seen as part of one ecosystem of decision-making. And this has led a lot of beautiful work at the global level after that. And I mean, for that, we are really proud. So after sort of the development of the framework, etc., I mean, we develop a regional action plan, which provides very clear sort of areas of actions for the member states in different areas. I mean, that this document is available through the link that I put here. And also for the WHO, commitment for WHO what to do, and commitment for the countries of the region. I'd like to acknowledge my colleague, Dr. Mehnaz Khairandi, who is not with us, and she was really an important player in developing the action plan and obviously in its implementation, and she's continuing to do that job very effectively. So when it comes to the sort of those areas, obviously, I mean, I'm bringing some key elements here. So, I mean, when we talk of knowledge translation, a lot of the focus is development of evidence-informed policy briefs and policy dialogues to support decision-making. That's an agenda we do in many countries of the region. I'm putting this about the work we did in Kuwait, I mean, which informed the national strategy for health, and also inform a lot of program that is continuing in the country beautifully. On HTA, obviously, what becomes a key aspect is the cost effectiveness element. Of course, it's not limited to that, and I'm not simplifying the process, but saying that element, within that, there is a challenge of how to develop the capacity in sort of to conduct those in the countries, how to bring the evidence, that so many different standards of conduct that should be developed, etc. Again, that's a separate area of work that we have made some methodological also breakthroughs in the last couple of years, and we are hoping that we will finish those to be able to share with the countries that have less academic capacity and less level of data, how they can benefit more from this program. And the last one that I'm going to refer to is the guideline. Obviously, when we talk of guidelines, and Lubna very beautifully explained, is we are sort of talking about answering the questions focused on a problem, whether it's a clinical problem, a public health problem, and health program problem. So questions that are addressing the sort of the natural questions that decisions makers are making. So within that, obviously, I mean, guidelines, GIN has been a sort of a major machine at the global level for enhancing capacity in that. I mean, I've attended not many, a few of GIN meetings, but some of them many, many years ago. And that agenda going, as you know, WHO develops a lot of guidelines for different priority areas of work. And many of colleagues who are on the call, I mean, they do similar works. I mean, I see many familiar names there. The focus we had in this agenda in the region has been on developing national guideline programs, not a single guideline, but a system that helps the country to address their own priorities via adapting guidelines that others develop to their context, or developing de novo guidelines when they need. When we talk of a national guideline, then we need to have a clear need to the national guideline program. We need to say, what do we mean by that? With that, I mean, we sort of conceptualize this approach in our work. As a national guideline program, it includes ecosystem, infrastructure, the laws and regulations that will be sort of behind it, the role of the stakeholders and the capacity, technical, financial, and human resource. Decision, clear sort of processes for development or adaptation of guidelines, the national bodies, the methodology, the sort of the priorities that to be addressed. And then obviously a program to follow that action. Obviously, a guideline that is not followed is a piece of paper, or nowadays a piece of software or a website. So for them to be effective, they need to have a dissemination agenda, monitoring of impact, sort of accountability measures linked with the accreditation programs, all of this together make a national guideline program. And this is something that even in countries that they develop guidelines, they may not have it all together. So in that sense, I mean, the work we did in the region, and in particular what we did in Egypt, which I refer to in a few minutes, is really key. In 2023, we did a survey of 18 countries of the region. We actually approached all countries, but 18 countries, all 22 countries of the region, 18 responded. And these are sort of, I mean, summarizing this infographic picture, the things that countries highlighted as the technical capacity was the most important issue to enhancing that capacity. The access to local data, and then obviously financial resources, the issue of evidence, and other things that are more global issues. And these have been also a focus of our work, and the webinars I referred to earlier are part of that program. And there are a lot of resources available on our website, WHO website in the region. So if you want to establish a national guideline program, countries need to deliberately answer three key questions. Why do they need that? For what purpose? I mean, what priorities they want to address by it? Who are the key stakeholders that are playing a role, and how they play their roles in the country? Some national guideline programs are hosted within ministries of health. Some are in independent bodies linked to the health agenda, health sector. And sort of, but then the roles of all the stakeholders, clinical societies, academic institutions, sort of insurance organization, accreditation bodies. And in many countries, the health sector has different hats. I mean, there are different governance mechanisms for it. So, I mean, not everyone reports to the Ministry of Health. And all of those have key roles to be considered. And then how? A key question is this one: to what extent the country is focusing on developing new guidelines, how they are going for the adaptation processes, adaptation of the existing guidelines, how they manage conflict of interest, etc. And sometimes, I mean, the easy answer might look as, oh, we go and adapt, but then adaptation of guidelines requires a lot of attention to the processes that should not be missed. And the experience in Egypt was really beautiful in these areas, bringing all of those together. So, I mean, this summarizing started with a high-level request from the Ministry of Health of Egypt, from the WHO to support the process, is sort of coincided with the establishment of the National Health Council in Egypt. and then the leadership of the National Health Council, as well as the Ministry of Health, were the guiding bodies on those processes. WHO started working, and by WHO, I mean my colleagues in the country office. I mean, I don't know whether my Dr. Naima Ghassir is on the call or not. I mean, she was she had a clear role there. And then obviously in the regional office, I mean, I had the pleasure to be part of it, but my key colleague was Dr. Mehnaz Khairandish, who is not with us due to sort of a conflict in the agenda. And then we involved so many other people. So I saw Professor Eli Ak from AUB with us. I saw other colleagues, I mean, on the call that have played a role in developing the capacity at the national level. And then it was became a national agenda launched formally by the country. Even after July 24, there has been more technical work with the country so that the program becomes independent of external support. Those technical rules are coming forward. As WHO, what we did also, we looked at the lessons learned. First of all, I mean, we published a story just recently, a couple of weeks ago in the EMAJ. So you can, in the bulletin of the World Health Organization, you can refer to that here. But key lessons from Egypt experience. High-level policymaker commitment is a key factor. If the High Council of Health in Egypt was not committed, if the minister was not committed, it would not have been possible to establish it the way it went forward. When you establish a national guideline program in a country, I mean, everybody probably would say, oh, that's a good idea. But usually every party would say, it's a good idea if you listen to the guidelines I'm going to present. National guideline program means that everybody should come together. Everybody should follow the evidence. So those normal boundaries between societies, committees, etc., should be broken, becomes a national enterprise. So high-level policymaker commitment is a key factor. The second part that we've done very beautifully in Egypt experience, bringing all the stakeholders on the table, is that sort of all the players, that whether they are supportive at the start or not, whether they have doubts or not. There were several interventions, gatherings, capacity buildings, discussions that brought different perspectives from different sectors together, and that really helped to take it forward. And then obviously, when the commitment is made, it's really important to link it with action, making sure the national capacity is expanded, policymakers see the fruit of the work and take that forward. As WHO, we did also something else. We used the experience to develop actually a guidance for other countries to develop national program for guideline adaptation. So this is not talking about methods on how to adapt the guideline. Those are, I mean, you can see them on beautiful documents, for example, from the great publications that they provide. That's not the purpose of this document we developed. It's actually talking about the key processes and key steps for a country to establish a national guideline program, not developing a single guideline. And that is also another byproduct that we develop. And then obviously we are in discussion with 2-3 more countries of the region to expand that experience. I guess the way we work with Egypt was probably also a unique experience, given that usually WHO is focused on guidelines for different problems, challenges, clinical problems, public health challenges. But then this was on national institution building, and this is again sort of a program that we are proud to follow with the countries of the region. So with that, I stop here, so I stop sharing as well. So back to you, Dr. Lubna.
Okay, thank you very much, Prof. Arash Rashidian, for the wonderful presentation. And honestly, I think your efforts are phenomenal in moving the whole region forward into an evidence-based culture and making institutional part of healthcare systems. And before we go further into the discussion, I thought we can have a group photo. So if it's possible, if you can put your cameras on, rather than just having the photos of the names. We need the photos of people.
While Yemen is doing it, let me also add, so the other key colleague, I mean, that helped the process in Egypt as well. I mean, in the later phase of it, I see his name is Yasser Sami, which is also a good colleague of Jean, and I want to acknowledge his contribution also to the Egypt program as well. So
wonderful, yeah. Yasser is active everywhere. He's been an important key figure in developing guidelines at King Saud University, Medical City, and but he's keeping links with Egypt as well. Okay, so do we expect more people to put their cameras on? Okay, that's wonderful, and honestly, seeing that there are many people who are interested in guidelines and in the region. The aim was to join forces and to know each other and to be able to work together when we have the dialogue. So the first objective of this session was to realize the basic role of GIN, that is networking. So I hope that this will be the platform where we start networking together. I'm just filling the time, by the way, in order for people to open their cameras on. I think we can take a picture now. Oops. So smile. Okay, I see that there's another page, but not, oh yeah, people are putting their cameras here as well, so I'm good. But it's okay, smile. Okay, I'll go back to the, okay, wonderful. So I'll take, I'll take the pictures again, 1, 2, 3. And then the other page. Okay, perfect. So, sorry. Okay, last time, I'm sorry for that. Okay. Okay, I think we're done. So it's now time to answer any questions or address any suggestions you may have. And for that, I would invite my colleague, Dr. Ghada Bawazir. Dr. Ghada Bawazir is very difficult. I would have a whole webinar to say who is Ghada, but she is a very active member in guidelines work and evidence-based work in Saudi Arabia, and she has we have worked together in so many aspects, and she's a Cochrane reviewer, she's a pharmacist, she's you can introduce yourself, Ghada. You can unmute, please introduce yourself and start the discussion.
Thank you very much, Lubna. I don't want to take too much of the participant time. I'm Ghada Bawazir. I'm a co-worker with Prof. Lubna and Dr. Yasser. We worked a lot with the guideline adaptation and definitely with different Cochrane reviews and stuff like that. And I think for now, I think our session is just to start the discussion part. And I was wondering if anyone have a discussion. If not, I can start with a comment that was posted by Prof. Mandir, if you want to share your proposal of the topic of having a like consideration for conducting a mapping survey. Because I cannot see any questions raised so far. So I think maybe we can highlight that with Prof. Mandir.
Thank you very much, Dr. Ghada, and thanks very much for everyone from Jinn International and Jinn Arab for inviting us to this wonderful webinar. My name is Ahmed Mendila. I'm professor of epidemiology at the Institute of Public Health in Alexandria. But formerly, I was coordinator of research and innovation in the regional office of WHO. I had the pleasure of working under the leadership of Dr. Rashid Diand, one of the two speakers this afternoon. And basically, it's my pleasure to just propose a mapping survey of what has been done in this domain in the Arab world at large. So, what kind of guidelines are available? Who developed them? Were they actually implemented? And if no or partially implemented, why? So, what were the challenges? And what are the best solutions? And it would be great that different stakeholders are implemented in such a proposal. So, this is for suggestion and for discussion. Thank you, Dr. Bawazir.
I think that's a wonderful suggestion. Thank you very much, Prof. Mendil. I wonder if Arash would respond to that, because I thought that there was something that is done, but I've never seen it published. But if that is not yet the case, I think that would be a wonderful thing to do.
There have been some similar work, but I would say there is still room for that. I think if I recall correctly, also Ellie did something a few years ago as well. We did something, but the focuses were not exactly what Ahmed is asking. We did also something focused on primary care related guidelines that I'm hoping will come out soon. But then the challenge of doing such surveys is that sort of when we talk of guidelines, countries and institutions and things, they refer to so many different things as guidelines. I mean, sometimes they are compressing ones, sometimes it's a piece of papers, a lot of time never published openly, etc. So establishing those, I mean, this could be also part of the capacity building. My suggestion would be that, for example, Lubna, through Jinn Arab, if these things can be taken as one of the initiative, would be of a lot of interest from WHO as well, and we will be happy to support it. I think that's a great idea.
Excellent, excellent. So we'll certainly discuss this with Jinn, and I think it can be supported. I will take the opportunity while Professor Eli Aql is with us. He's the liaison from Jinn board to Jinn Arab. So he's a member of the Jinn board, and he's the one who's the liaison person for this regional community. So would you like to say something in this event? Thank you.
Thanks, Dr. Lubna. Thank you. I appreciate it. Thank you, Dr. Arash and everyone. If I could speak on behalf of Jinn to say that the Jinn board is very, interested and invested in supporting the regional communities because this is where the capacity is, this is where the needs are that we need to follow. And particularly in the Arab region, as we know, and it has been, mentioned, we have lots of capacity. We don't lack the expertise, we don't lack the passion, we don't lack the interest in practice guidelines, and we have many leaders in the region that we've heard speaking and others that have not spoken. I think what we're missing is that implementation piece and the concept of how to institutionalize. That Arash mentioned, and this has always been a challenge. And I think to some extent or at some level, the issue of institutionalizing is kind of a political decision where there is a need from the political leadership to say, the practice guidelines are either going to be used as part of regulations that people would need to use them. They have to show meeting certain criteria for quality practice. Or incentivize in some way. Otherwise, I think people are, particularly in our area, like to practice the way they like to practice. So I think rethinking about, how to force implementation, if I could say, or incentivize implementation is a key aspect. Because as Arash mentioned, and, as others have mentioned, people have done the surveys, they have done the studies. I think what we need next is to push that, last barrier of implementation.
Yeah, the sensible use of guidelines, putting them into practice is vitally important. So thank you, Professor Eli Aql. There's
I see a
someone,
hand, someone, but
yeah,
no
I don't
name.
know. He's an iPhone, so but there's no name. There is a raised hand. So
There's a question.
would you like to unmute, introduce yourself? If you can put your camera on and go ahead and pose your question or comment. Yeah.
Hello, maybe that's me, right?
Yes, you are.
Yeah, okay. First, thank you so much for this very interesting presentations. I'm Dr. Sumaya Lariki. I'm from Yemen, and actually, this whole discussion is coming at the time I am doing my PhD at the mid of all this work. So, evidence-based healthcare, implementation science, guidelines, and so on. So I'm very, very interested in the whole discussion. I'm, by the way, an ex-WHO. I worked in the health system department in Yemen. Where my focus was in improving quality of care. And I'm currently a lecturer at the university. My question is about, so we're having this work in the region, while we know that there are large variations among the countries in the region. So we're knowing those socio-economic, political variations across the different countries in the region. And I'm wondering, how are we considering all those differences while we are moving forward this agenda? Because we are also having knowing that some of the countries in the region are having very specific challenges they're facing. And I'm sure that this is considered in this agenda, and would like to hear more about it. Thank you.
Okay, beautiful. And I'll, for Gen Arab, we're just starting, but maybe I'll hand over the question to Prof. Rashidin.
Yeah, I mean, that's a valid question, and it doesn't apply only to guideline program for any program that we consider. I mean, we need to consider the sort of the capacity, the resource. Any program has its own cost. So, for example, I mean, you establish a new program, there will be experts that will be involved, there will be processes that will be occupied into that process. So we need to make sure that adds value to the priorities of the country. For a country like Yemen, I mean, Yemen has is affected by conflict for many years. There are economic and political challenges there. But the country size of Yemen definitely needs a full-blown national guideline program. So that if you think of a vision for the future, even in the current context, maybe the focus could be emergency guidelines, adapting from the context, the things that are priority of the country. I know, for example, in certain areas, Yemen has also a lot of positive experience for doing that. Many years back, I mean, in my prior WHO work, I remember the work, for example, in Yemen, that were doing how to adapt WHO guidelines for addressing malaria for the context of Yemen. And then it was also in different parts of Yemen, I mean, the coastal areas, the mountain areas, the desert areas, how to sort of revise those processes. If these become a program, then obviously, even in the emergency context, that's doable. Then you define the processes differently, you define the requirements differently, and you do it in a way that would respond to the priority needs of the country. Absolutely. I mean, as WHO, we will be more than happy to support establishing such an agenda, and we work very closely with the Ministry of Health in Yemen in any case. And I mean, as she mentioned, she's ex-WHO colleagues, and she knows that the country office in Yemen is also very keen to do this. I mean, if it comes from that angle as a demand, I think that can be done. Then obviously it should be focused on what are the priorities and sort of requirements for the context of Yemen.
Yeah, what I like about the plan that you have presented was that you tailor it to different needs of different countries. So for Yemen the needs might be different, but the resolution have put a requirement from each country. So each member state in that country regional office is required to provide its plan for guidelines and for other aspects of the beehive shape that you have presented. So it's great when Yemen is talking about establishing a national program, but what I'm trying to say through the lens of an Arab GIN or a regional approach is that there are capacities here and there, but we don't talk to each other and we don't make use of each other. And
Yep.
I know that WHO, EMRO are doing fantastic work in order to push countries, but at a ministerial level, maybe through GIN Arab, the regional community, maybe we can do things that are not necessarily very high level, but these are people and champions who are here and there in different countries. We can talk together and we can work together so that we achieve something. We can achieve something. It doesn't have always, although I agree that the ministerial or the high level commitment is important for sustainability, but at least the beginning could be on a smaller scale between people like us. I'm no longer in the leadership position for guidelines, but people who are clinicians, educators, whatever, NGOs, and then we can organize ourselves. And I hope that the region, GIN Arab, would support, and I'm sure Eli is here, so he's providing his support, and the board would, in order so that we can join forces and produce something together that would support the leaders in achieving this resolution. So.
Yeah, I would definitely second that, but I wouldn't you introduced it as a very humble proposal, but I would say that's not a sort of a small thing. That's actually a major thing. It's not about the agenda. It's actually about how to address the problem. That would be a really good, another action, perhaps, Lubna, from your side. So if there are topics that require a guideline that has not been well addressed with the existing guidelines in the region, and a few countries of the region are interested in doing that, that would be excellent. As you mentioned in the regional action plan, we categorize countries according to the sort of technical capacity, the population size being affected by emergency or not, and that's a general guidance that we do. But the level of commitment we also have, depending on the level of needs is different. Countries that have more needs, the commitment of WHO to that would be bigger. So, but then, I would say finding topics that would go beyond one country, or even if it's in one country, but it's a major issue that has not been well addressed with existing guidelines, that would be really, and that's not a humble thing to do. It's actually a major thing to do and would be really good to plan doing that.
Yeah, sure. Yeah, sure. Thank you. And we'll work of that. Maybe I personally have the advantage that I can see both sides, and I see what is doable via the WHO and what is doable via GIN. Eli has a comment, and I think I know what you are going to say, but go ahead, please.
Thanks, Dr. Lubna. Actually, I wanted to follow up on what Arash is saying, and I think that makes sense. It's getting people to collaborate in the region, we know it has been very challenging. But maybe there are opportunities with some specific topics that are of common interest, but maybe also specific to the region. So the one topic I'm thinking about is wound infection in conflict setting. Unfortunately, we live in a setting that is affected by many recurrent conflicts affecting most of the countries in the region. And this is an issue where there have been lots of studies about multi-drug resistant infection that develop in those kind of contexts. And again, this is of common interest. This is affecting public health in different ways. But also this is an area where we do have that specificity that no other region in the world has, unfortunately. So why not, come together and address this topic? We could be kind of leaders on the global stage in that topic. And then working with WHO, EMRO, or even with WHO headquarters, I think we have we have both the capacity, the interest, and the background to do this. And the question becomes, how do we push that agenda forward? It doesn't have to be this topic, but I'm just giving this topic as, again, a topic of common interest, but also specificity to the region.
Okay, shall we take one more question? All right. There's a question from Nancy Shaib. She said, how are you handling the challenges of lack of local data? And there's a follow-up from Titania saying that the American College of Physicians developed guidelines based on all available evidence, including clinical trials and observation data. However, finding peer-reviewed publication of research from the Arab countries is not that easy. So both of the questions asking about the challenges of using local data from clinical trials. For example, she mentioned that there in 2025, the Saudi clinicaltrial.gov showed that there are 474 pharmaceutical biological studies, 50% of which have been completed, and the results are posted. So again, what are the challenges and how can we overcome the challenges of using the local data in order to derive a conclusion or the guideline recommendations?
Maybe I give it a stab, and I note that we have 3 minutes left. So very quickly, I mean, the question has many thanks for both comments. I mean, both are valid observations. And it has a sort of, I would say, generic response and then a specific response. The generic response these are challenges not only for low middle income countries or countries affected by emergency or high income countries in our region. It's a global challenge. I mean, so I remember the GIN meeting in Glasgow. A lot of the use of local data challenges are actually coming from European countries. So it's the nature of the challenge is different, but the challenge is there. So with that, I would like to refer you to the capacity buildings that we did for Egypt purposes, but it's online available, including the program that Eli and his team conducted for colleagues in Egypt. So those are, I mean, they address the generic approaches, how you go for those, how you take that forward. But when it comes specifically for each guideline and each technical and each clinical or public health question within the guideline, then addressing that would require a lot of attention, sort of, I mean, whether you can rely on similar data or not. And those are decisions that the committees need to make and take that forward. Sorry, I'm losing my voice now.
Anyone has that?
Okay, so I think at the moment we're having some data that are possibly there that can be used, but they are not enough data. But we can at least manage to make use of the evidence, the research evidence that is available, and then we can add the data or combine data or use the GBD data until we have real life data that are from the from the ground. I understand that we only have 1 minute left for the end of this webinar, and I'm glad that the interaction is moving. So is it okay if we continue for 5 minutes more, or?
Yes, please do.
Okay, fair enough. I think I've seen more questions, Ghada, coming up.
Are the challenges establishing I went with Dr. Ram's Banjar question. What are the challenges in establishing multidisciplinary guidelines, and how could we resolve this? There's also, so that was one of the questions that was raised. How can a member of the GIN, that's from Brenda, from Egypt, she said, how can I be a member of the GIN? So I think maybe I refer you to the GIN admin, just to be a member of the GIN regarding your questions. So,
yes.
Go ahead.
Okay, how can you be a member of the GIN? There are a number of membership models that are used. It is encouraged to be an organizational member. So the whole organization you are working in would be a member of GIN, whether it is a small organization or large organization. But if that is not possible, I believe GIN would still allow individual membership for 1 or 2 years till you manage to encourage your organization to be a member. But I would say that you can go to GIN website and read more about the membership. And I would like to thank Professor Rashidian. He said that he had to leave. Thank you very much for the wonderful presentation. I think he already left. Okay. As for the question on the challenges, that's a long, an important question, but that would take another webinar maybe, because that is a very deep question that would open up so many levels and so many things to be discussed. But I would say that this question would be covered little by little in the next webinar series. It's important that we keep receiving your questions and your suggestions for topics to be covered either via webinars or other formats where we talk together and start to work together. For example, Elise suggested wound infection. I know that diabetes is important, and the colleagues from Tunisia are going to cover that in an upcoming webinar. Somebody suggested obesity in the chat, and maybe more topics were suggested. So just we need to keep the dialogue going on. And the last 2 or 3 minutes, I will hand over to Dr. Zidane, Lily Zidane from AUB, to talk about the next webinar. I'll probably, until she's here, I'll just show you this. This is the topics that we thought of covering till the end of 2026, but we haven't yet set the agenda for 2027, so we're open. So the next webinar is going to be organized by Dr. Lily Zidane from the AUB, and she'll talk about it in a moment. And then another presentation or another session on grade and NGuide organized by Joanne Khabza from the AUB and Nasser Aboujain from our team. The fourth, and that would be in probably in November, will be Adapting Global Evidence for Local Impact, organized by Yasser, Dr. Yasser Amir, Nasser Aboujain, and Marwa. The last one in December is by the team from Tunisia, Mohammed bin Hamouda and Hala Qortat, and colleague Hiba Abdulazim from Germany. And that is about obesity guidelines. So the floor is yours now. Lily, تفضلي.
Thank you, Dr. Lubna, and thank you everyone for this session. As you know, this is the first webinar in a series, and we look forward to seeing you all in the next one. The next webinar is titled Doing More with Less, Regional Guideline Success Stories. And so in this session, we will showcase 2 successful guideline initiatives from the region and explore the principles underlying these success stories despite having constrained resources in the area. And so the aim is to identify feasible steps that you can locally adapt to strengthen your guideline activities. And so the webinar is set to be in August, and therefore I invite you to keep an eye out for the official GIN announcement, and we look forward to seeing you all in the next webinar. Thank you.
Okay, thank you very much. Thank you, Lily, and I'm sure that it's going to be a very interesting webinar. I think I saw, that's the very last thing, I think I saw Dr. Shukri Hamouda, you raised your hand. but I was
Thank you.
so many messages were coming at the same time. I'm sorry.
Thank you, Dr. Lubna. There is two sides of this topics. There is the side we talk about that adapting a guideline for our Arab region, and the other side, professional who will use this guideline in practice and every days, and we will evaluate that. For that, there is a relation between guidelines production and CPD, continuous professional development. So actually in the Arab board, I am a professor of medicine and I am a president of CPD unit at the Arab Board of Health Specialization. I am from Tunisia. For accredited credits hours in CPD, we have to demonstrate that professional has the latest adapted guideline to our region. We are working now on that. I will invite Dr. Lubna to teach with us these topics. So we will have more and more collaboration in the future. Thank you.
Okay, fantastic. Thank you very much, Dr. Shukri. And I believe there is a working group on education as well. I don't know what are their plans, to be honest, but one of Jin's working group is about education. So I'll find out with them also whether we can collaborate with them or not. But anyway, I'm so glad about this engagement and this interaction going on. If there are no final burning comments, we'll probably put this webinar to a close. And thank you very much. Thanks for Jin for organizing this and for encouraging us to talk. And that's the beginning. And I hope that it will be followed up by more successful and more deeper engagement and deeper disseminating the culture. As I said, the objectives were to introduce the audience to Jin and Jin Arab, and I hope that we have managed to do this, to come to a common understanding of what guidelines are, the standards, methodology, tools for development, appraisal, implementation, the science of developing guidelines. We've just started today, but there will be more things, deeper things in the future, and to showcase the status of guidelines in the Arab world and how we can move things forward. So we haven't done much about that. Well, the most important thing is that we have presented the WHO EMRO efforts and the ministerial resolution of the Arab Regional Committee meeting in 2019 about their commitment to institutionalizing evidence in policy making. I think that is a background resolution that should be at the back of our minds, all of us. But how can we do it on the ground, and how can we do it for our patients and for all who are affected by our role as whatever roles we are doing, our roles as physicians, as educators, as social worker, human rights activist, whatever, is to be discovered later on in future webinars, inshallah, hopefully. So if there are no final comments, we'll stop here. Thank you very much, Rosa, and thanks for all of you, lovely audience. Thank you, Dr. Ghada, for this. And we look forward, we'll keep you updated with information from Lily about the upcoming webinar. And we might be meeting in person in Kuala Lumpur in September. I hope that that would happen. We managed every conference, some of us, at least like 10, 15 people are there. So little by little, we will come to meet each other and learn from each other and move forward in the field of evidence-based guidelines. So thank you very much.
Thank you very much, everyone. I'm now going to close the webinar, but we will share a recording with every participant sometime this week, once we've collated it. But thank you, everyone, for coming, and thank you very much, Lubna, for all your work on this and for speaking.
Thank you. Thank you very much. Bye-bye.